button, and we are live. Hello, 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 everyone. Welcome, welcome, welcome. Tonight, I have something extra special for you. Our guest is Dr. Neera Dahl MD, PhD, expert in ADPKD, the dominant version of polycystic kidney disease, senior associate consultant at the Mayo Clinic, and director of the PKD Foundation Center of Excellence in PKD at the Mayo Clinic in Rochester. Her main focus is on ADPKD and other cystic diseases that mimic ADPKD. She is currently on the faculty at the Mayo Clinic and has an adjunct appointment as professor of medicine at Yale University School of Medicine, the section of nephrology. She had been at Yale from 2007 to February of 2023, where she was instrumental in developing the Yale Inherited Kidney Disease Clinical Program and was the principal investigator for several ongoing clinical trials in ADPKD and maintained an active role in the ADPKD registry. Her educational background is outstanding. She received a Bachelor of Arts degree from Johns Hopkins in 1987. She graduated from Tufts University School of Medicine in 1996 and Tufts University School of Graduate Biochemical Sciences with an MD and a PhD. She completed her residency at Beth Israel Deaconess Medical Center, a major teaching hospital of the Harvard Medical School, in 1999, and she became a fellow in nephrology from Beth Israel Deaconess Medical Center in 2002. She has won multiple honors and recognitions for her work over the years, and I mean multiple, my friends. If you want to know more about Dr. Dahl, if you go to the original broadcast that's pinned to the top of my individual Facebook page, all kinds of information on her, including information about her honors. So, well, without any further ado, welcome, Dr. Dahl. How are you?
I am doing great. Thank you so much for that kind introduction. I'm really delighted to be here and spend some time talking about PKD.
All right. Did I state everything correctly in the introduction?
Yes, it was a very nice introduction.
Please tell us about where you grew up, your education, and your employment experiences.
Sure. I was born in India, but I grew up in Maryland. I came to the U.S. as an infant with my parents who immigrated at that time, and went through the U.S. school system in Maryland in the public schools, and then went to Hopkins for undergraduate, and from there went to Tufts for the MD PhD program, and stayed in Boston at the Beth Israel Deaconess for residency and fellowship, and for the first few years as an attending, and then came to Yale. And at Yale, I really started to differentiate in working in the inherited kidney disease space I had done my PhD in another kind of genetic disease, a lysosomal storage disease called Niemann-Pick type C. So I already had some background in genetics and some background in understanding inherited disease, although not polycystic kidney disease. And the interest in polycystic kidney disease at Beth Israel Deaconess, Ted Steinman was one of the main figures there who really, well before people really understood a lot about PKD, had developed a nice PKD program. He had recruited patients into one of the very early studies on PKD, which was the MD-RD study, which is a diet intervention study looking to see if low-protein diets affected outcomes in PKD. And then I went to Yale, and the division chief at Yale is Dr. Steve Somlow, who is famous for having cloned PKD2, having discovered and cloned PKD2, which is the second gene that causes most autosomal dominant polycystic kidney disease. And so I was in a really strong PKD environment, and it was a great place to develop an expertise for patients. So we started doing a lot of clinical trials at Yale, including the clinical trials, the pivotal ones that were important for tolvaptan. So we were a big site for all of those tolvaptan studies, and then for the additional drugs that have been developed since tolvaptan. Most of those have not been successful. But I learned.
Oh, I'm sorry. Go ahead.
Go ahead. A lot about PKD during that time, and I think that's where I developed a lot of my experience with PKD and PKD patients.
Let's talk a little bit about polycystic kidney disease, which we're referring to as PKD. What are the causes of PKD?
So a few years ago, maybe 5 or 10 years ago, we would have said that PKD is caused by a change in one of two genes. And the genes that we knew about were called PKD1 and PKD2. And PKD1 is probably about 75% of the population with PKD. PKD2 is about 15%. And then there's a subset of patients where we are not able to identify a variant, either in PKD1 or PKD2. And that is still true, that the majority of PKD is caused by a change in either PKD1 or PKD2. But what we've learned is that there are some other genes that also act in a way that seems autosomal dominant that can lead to cysts within the kidneys. And in PKD, as you know, you can also have cysts within the liver. And so you can get this phenotype or this clinical story of someone who has both liver and kidney cysts, but that gene that's causing that may or may not be PKD1 or PKD2. It may be one of these genes we think mimics PKD1 or PKD2.
Please explain how the mutated gene is passed from parent to child.
So the gene is in all of the cells in the body, which means that as the cells are being differentiated to make either an egg or a sperm, each egg or sperm will carry one copy of a gene. And each person has two copies, right? One from mom and one from dad. And so during gametogenesis, during this time when the egg and sperm are forming, they'll get one copy, one from mom or one from dad of each gene. And those are the genes that then get passed on to the next generation. And so each person with ADPKD has a 1 out of 2 chance of giving the disease to their offspring because they'll get either the gene that contains the gene that has the change in it, or they'll get the normal copy of the gene. And so each child has a 1 out of 2 chance of getting the disease.
What if both parents have the mutated gene?
So if both parents had ADPKD, then each child would have a 1 out of 2 chance of getting the ADPKD causing gene from mom or from dad. This is an autosomal dominant condition, and we think people that have 2 copies of a disease causing PKD1 gene or a disease causing PKD2 gene won't survive. So the offspring that survive will have either mom's PKD1 gene or dad's PKD1 gene, or they will have neither, and they'll be perfectly normal, right? So it's a little bit different. This is a disease that I'm talking about specifically about autosomal dominant polycystic kidney disease. There's another disease that's very similar. It's called autosomal recessive polycystic kidney disease. Autosomal recessive polycystic kidney disease, in that condition, both mom and dad, they're carriers. So it means that mom and dad both have one good and one disease-causing gene. And so in that scenario, you can have a 1 out of 4 chance of having a child that has the autosomal recessive disease, a 2 out of 4 chance of having a child, or a 1 out of 2 chance of having a child that's a carrier, that's just like mom and dad, and a 1 out of 4 chance of having a child that is normal and has both normal genes and does not have the variant, the ARPKD variant. So it's a difference, like the difference in what you expect in the offspring is determined by whether the gene is dominant or recessive.
Okay. Talk to us a little bit about the complications of PKD.
So PKD is a systemic or multi-organ disease. We think of it by the way it's defined by having cysts in the kidney. And we know that in the kidney, there can be kidney cysts that can lead to loss of kidney function. There can be kidney stones. There can be high blood pressure because of those kidney cysts and impact of the kidney function. But the PKD also can affect other organs. So people can have cysts in the pancreas. People can have cysts in the liver, and that becomes much more common with age. People can develop weaknesses in the vasculature. So we particularly screen people who have a history of intracranial aneurysm in the family, or a history of bleeding into the brain, or rupture, sudden bleed into the brain. We screen those folks to see if they could be carrying an aneurysm in one of the arteries that feeds the brain. So we look for that. Men with PKD can have cysts in the tract that is important for reproduction, and so they can often have infertility issues. So there can be, those are some of the common complications of PKD, but certainly there are others as well.
I understand that some of the complications are preventable, others are manageable. What can be done to reduce the damage to your kidneys from complications like high blood pressure or kidney failure, that sort of thing?
So there are a few different strategies that we employ. The first and foremost, we talk a lot about lifestyle and diet modification. And really what we're encouraging people to do is have an active and healthy lifestyle, maintain a good body weight, to not smoke. And then in terms of the things we tell everyone with kidney disease, is to follow a low salt diet, to follow a diet that's rich in fruits and vegetables. And you know, in PKD, we think that the PKD cells grow on glucose. So we tell people to avoid, except as treats, really a lot of high concentrated sweets and things like that. And then also recommend just sort of being mindful of eating. Like, I think that's one thing that people can do all the time, of having good fluid intake, because we know the hormone vasopressin, which responds to dehydration, can activate the cyst growth in PKD. So the first thing is all of these diet and lifestyle things. We monitor for high blood pressure very carefully. We start treating for high blood pressure earlier than your primary care doctor or internist might decide to start treating for high blood pressure, because we know that that's important in limiting cyst growth. We then, for people who are at highest risk of progression, we talk about another medication called tolvaptan, which specifically blocks the kidney's ability to make a concentrated urine by blocking the effect of vasopressin on the kidney. And that seems to really slow down the rate of progression of loss of kidney function for those people who are at highest risk.
Okay. Little shout out to Jonathan Traylor. Jonathan's from Kidney Solutions. He's a friend of the show. He frequently checks in with us, and he shares all our broadcasts. So we love Jonathan. Our friend Elizabeth Sterling is checking in. She's a PKD patient herself. She's been on Jarnique for the last 8 years and is getting ready to start dialysis. Our good friend Lisa Woods is here. So you've got a few people that are keeping an eye on us tonight, Doc.
Good. I'm happy to hear that.
Let's talk a little bit more about tolvaptan.
Okay.
It's my understanding that the medication can help to slow down the growth of cysts that are a part of PKD. Can you talk to us about tolvaptan's benefits and side effects?
Yes. So tolvaptan is the type of drug it is. It's a vasopressin receptor antagonist, which means that it blocks the effect of vasopressin. And vasopressin has kind of a bad name, but what it does in the kidney, the other name for it is antidiuretic hormone. So what it does is it helps you retain water. So if you haven't, if you're dehydrated, you haven't drunk a lot, then this hormone gets activated, and it helps maintain your blood pressure. It helps regulate how much urine you make. When it's activated, you make less. When it's not activated, you make a dilute urine. But we think that this drug in particular, through a messaging pathway called cyclic AMP, so we think that vasopressin causes increase in cyclic AMP, and this leads to cyst growth, both by fluid secretion into the cysts and also by permitting the cyst cells around the cyst walls to grow, to get bigger and bigger. And if you give tolvaptan, you block the effect of that cyclic AMP and block some of the cyst growth. But we think that there are two effects of tolvaptan. We think that initially there's a benefit in terms of it reducing the rate of kidney size, but then long run, we think that there's a benefit of it in that it slows down the rate of loss of kidney function. And usually that change is about 1 ml per minute. So if you're at that stage of kidney disease where you're losing kidney function at 4 mls per minute, then now on the drug, you'll lose kidney function still, but it will be at a slower rate of 3 mls per minute. And so that 1 ml per minute per year, we think, is additive. So the earlier you start, the more benefit you accrue from the medicine in terms of delaying the time before you need dialysis or you need to get a transplant before the kidneys fail. So we really try to target folks who are younger, who maybe still have good kidney function, but we can tell by their kidney size that they're at risk. We really try to target those folks and say, you know, the folks in their late 20s, early 30s, or 40s to come talk to us and see if they would be candidates for tolvaptan therapy. And then you asked about the side effects. So if I block the effect of vasopressin, then you tend to make a dilute urine. And so most people who stop the drug because they just find that they're urinating too frequently or too often, and it's disruptive to their lifestyle. And particularly people who have jobs where they cannot use the restroom. So one of my patients who was a waitress, or one of my patients who was a warehouse worker where he really needed to be on the floor all the time, both of them found it intolerable to be on this medication. There are some other people who it's not a great medication for other reasons. And then we worry about this drug potentially causing liver toxicity. So when we prescribe the drug, we prescribe it very, very under very carefully controlled circumstances, where we're checking the blood work before the person starts on tolvaptan. We're checking 2 weeks after. We're checking 1 month after, and then we check every month after that for the first 18 months, and then every 3 months after that while they're on the drug.
Okay. This urination problem, it can also interrupt your sleep. Is that correct?
Yes, it can. So the people that I know that have stopped it, they've stopped it because of either it's disrupting their lifestyle, their ability to work, that kind of thing, or they're waking up too frequently. We have some tips and tricks for people who are on tolvaptan to try and eliminate that having to wake up at night. So one of those is we tell you to take the first dose as early in the morning as possible, so then you can take the second dose 8 hours later. And if you can take the second dose by about 2 or 3 in the afternoon, then by the time you're going to bed again, the medicine should be wearing off. We know that the more salt you have and the more protein you have, the more you'll be bothered by the urination. And so we really, before even people start on drug, try to teach people how to follow a low salt diet, which is easy in theory, but very hard in practice for anyone who's tried to do it. And especially if you're eating out or using prepared foods or sauces or mixes or things like that, it's incredibly difficult to follow a low salt diet. But we think those two things can make a big difference in how tolerable the medication is. And also, the lower the dose, the less there is of that aquaretic, that sort of frequent peeing and side effect. And so we can sometimes lower the dose to find an appropriate dose for people.
Okay. Some of our guests are saying that you have to stick with tolvaptan, and it might be a little rough at first, but as you're saying, adjustments can be made, and it tends to get better the longer that you're on it.
Yeah, and I think that sticking with it is really, really important. I think what your other guests are telling us is what we've seen, which is if we can get you past the first 3 or 4 months, then you'll have made the adjustments that you need to make to be able to stay on it for a long time. And, people do get used to this new lifestyle where you're drinking frequently. The drug makes you thirsty, so people don't usually complain about having to drink. They're happy to drink, but the frequent urination is what really bothers people the most, I think.
Are there other medicines currently available or in development that do some of the things that tolvaptan does, like slow the growth of your cysts or lessen the amount of actual kidney failure that you're suffering in a given period of time?
So there are other drugs being developed, and after tolvaptan came out, the first few drugs that came after that did not make it past the phase 2 trials. So they didn't make it into the large scale clinical trials because we didn't see enough of a benefit from them in the early stages of those trials, but there's some now that are coming into the clinical trial space. So one of them is a drug by Regulus, and it's a completely different mechanism of action. It doesn't have anything to do with tolvaptan. But in this case, what happens is there's a bit of RNA that blocks the transcription of polycystin 1 and polycystin 2. These are the proteins that are made by the gene PKD1 and PKD2. So there's this regulatory piece of RNA that all of us have that sort of keep the expression of these polycystins low. And the drug that's being developed antagonizes the effect of that RNA. So it's that RNA is called MER17, and it's a MER17 antagonist. And so the idea then is that you get more polycystin production, and so people have less cyst growth and less loss of kidney function. So that trial is right now in a phase 1 trial. They're trying it out in a new formulation to see if they can see the impact of that, and we're hopeful that will go well. There are other drugs being developed that are looking at different pathways for intervention. So we know that the cyclic AMP mediated pathway is important, but there may be other ways to target that cyclic AMP mediated signaling besides just blocking vasopressin. So people are looking at that. There's another pathway that's important in cell growth called the mTOR pathway, and there's a drug being developed to block a part of that pathway called TORC1. And so these are some of the new drugs that we're starting to talk to some of the companies about, that they're developing and are pretty excited about what the impact might be. So I think, just like in the early days of high blood pressure or in the early days of treating heart failure, we only had 1 or 2 drugs. I think we're in those early days for PKD. And then hopefully over the next, 5 to 6 years, we'll see that we've got now, instead of 1 drug that only targets a certain part of the population, we'll have many more drugs that are available.
All right. Let's talk for a minute about the symptoms of PKD. Let's assume that your Uncle Jim is a new PKD patient. What symptoms should cause you to seek medical attention?
So first and foremost, if you're having really severe pain that's out of the ordinary, I think that's a warning sign for anybody, but severe pain and a fever could be a sign of an infected cyst. If you're having a lot of pain, it could be bleeding or rupture of a cyst. It could be a kidney stone. So I think, the things that need urgent attention, usually your body is warning you that those things are happening by the pain and the symptoms that you're having. If you're all of a sudden feeling weak or lightheaded or dizzy, then we need to know about those symptoms too. Otherwise, for people who are being well monitored in clinic, we're following the kidney function, and we're really looking for changes that tell us, okay, now someone is progressing. Now it's time to adjust the medicines. Now maybe it's time to start talking about either dialysis or transplant, or sort of what the next steps would be.
Okay. You have mentioned that there are 2 types of PKD, the autosomal dominant polycystic kidney disease, ADPKD, and the autosomal recessive polycystic kidney disease, ARPKD. I understand that most people with ADPKD have defects with the PKD1 gene, about 1 out of 6 persons. Is that a correct understanding?
So a lot of that is correct. So there are ADPKD, we think it's mostly because of PKD1 or PKD2 as the genes that are involved. And you just need one disease-causing copy of one of those genes to have the disease. And we think that the prevalence is something like 1 in 500 to 1 in 1,000. So not quite the 1 in 5 that you were talking about. The other disease, ARPKD, so it's much more rare. It's a recessive condition. It's 1 in 20,000 for the population, so much more rare. But the carrier rate for that, so people who have that one gene, but not both genes that would cause disease, the carrier rate for that is higher. So the carrier rate is about 2%, 1 to 2%. So that means 1 to 2% of the population, 1 in 100 now, or 2 in 100, have carried that gene. And that gene is called PKHD1.
Okay. I understand that 1 out of 7 people with ADPKD have the PKD2 mutation gene. Is that correct?
Yeah, so I was breaking up the numbers a little bit differently, but I would say all of us agree that PKD1 is the predominant one. Somewhere about 75% of people have that, and PKD2 is the less common one. So somewhere around 15% of people have that. And I think that's roughly the numbers you were quoting too, Jim.
Okay. I have read that ADPKD, the more common type that you refer to, affects around 600,000 Americans and 12.4 million people worldwide. Are those fair statements?
Yeah, I think that's about right.
Okay. The other thing that I've been through, and I have a son that's been tested too, is it true that the signs and symptoms of PKD don't really develop or become detectable until a person is around the ages of 30 to 40 years old?
It depends really on the type of genetic variant. There are certainly some kids who are diagnosed as early as in utero. So even when they're inside mom, right, when they do the ultrasounds, those prenatal ultrasounds, they can see cysts on the kidneys. Some kids are affected with ADPKD. So there are kids with ADPKD who have high blood pressure, who usually high blood pressure and cysts in the kidneys, but they don't lose kidney function until they're older. Most people with ADPKD develop symptoms sometime in the adult range, right? So sometime in the 20s to 30s. It could be a kidney stone that then leads to the diagnosis. It could be blood in the urine. It could be high blood pressure, and people don't know why they have high blood pressure, so they do some imaging and see the cysts in the kidneys. But the disease is very variable depending on the specific variant or mutation that's causing the disease.
Okay. You mentioned children can develop ADPKD. Is that correct?
Yeah, that's right. So the cysts start forming as soon as, like, the cysts start forming from birth, right? The cysts are forming as the child is forming, and it's really just, are there enough cysts that the person becomes symptomatic or not? Are there enough cysts that we can tell from seeing the patient from the outside is something going on or not? And usually the first sign of that the kidneys are enlarging to the point that there's a problem is development of high blood pressure. So what we tell families of, the parents of kids who may have PKD is, you don't necessarily have to test the kids early, but when they're going to their pediatrician, when they're getting those well child checkups, to have their blood pressure checked, right? Because that's really critical. If we're going to see something, we're going to see it then. If if the child is complaining of back pain, or you see some blood in the urine, or there's some other sign, then that would be a reason to do more of a workup.
Okay. Let's talk a little bit about autosomal recessive polycystic kidney disease. As you mentioned, this is a version of PKD that is less common, and it affects like 1 in 25,000 children worldwide. Can you tell us a little bit about ARPKD?
Yeah, so ARPKD is recessive, meaning you need to inherit one disease causing copy from mom, one disease causing copy from dad. You have to have basically two genes that are not functioning to have the disease of ARPKD. This is a disease, unlike ADPKD, where it's unusual to see it in children. This is now a disease where it's very common to see it in children. And sometimes it's common even in utero or at, in those very early days after birth, because the baby's kidneys help make amniotic fluid, and the amniotic fluid is important for lung maturation for the babies. And so if the baby's kidneys are big or they're not functioning in utero, the babies are often born with very big bellies because they have very large kidneys, but they may also be born with breathing problems because the lung maturation was not normal. And so those babies can often be very sick in their very, very early days and require a lot of special care. And that disease is almost always picked up in utero for the kids that are very, very severely affected. But then a lot of children will go on to develop end-stage kidney disease at a fairly young age. And so that might be a reason that a child, for example, gets a kidney transplant because of ARPKD.
Okay. The signs and symptoms of ARPKD can appear shortly after birth, but sometimes they don't appear until later in childhood or adolescence. Would that be a fair statement?
Mm-hmm. So just so it, everything has a bell curve, right? So there's an average for everything, but then there are the like sort of the outliers, right? So we say in general ARPKD is a disease of children, but there are some people who don't get diagnosed with ARPKD until they're adults because they have milder disease and they've just escaped detection until that point. So yes, those are all fair statements that mostly this is a disease that causes kidney failure in children, but that it can sometimes be seen in adults.
Okay. It's my understanding that both parents must have the abnormal gene to pass this form of the disease to their child. And if both parents have it, the child, as you've mentioned, has a 25% chance of getting the recessive version of the disease. Are those fair statements?
Yep, that's exactly what we talked about earlier. That's right.
Okay. Unfortunately, is it true that ARPKD can cause death in the first month of life? But these days, almost 80% of the ARPKD children survive this period.
Yeah, so we talked about that the babies may have may not have proper lung maturation because they're not making amniotic fluid in utero. And those are the babies that don't survive those first few days of life because we can't do anything further to help with the lung maturation. I mean, we try and there are medicines that we use, but the babies that don't survive that time period, that's why. The babies that are not as severely affected, who have better lung maturation, are the ones that survive into the early childhood years and may do very well for some time and then may develop worsening kidney disease over time.
What, if anything, can be done to extend the ARPKD patient's life?
So a lot of the same medicines that we're using for ADPKD may be beneficial in ARPKD. There's a study with tolvaptan going on now to see if tolvaptan is beneficial in ARPKD. So that is being actively studied. We know that anybody with kidney disease benefits from being on blood pressure lowering medication, on having all of those other diet and lifestyle issues that we talked about earlier addressed. If we know that the kidneys for the child are failing, right, then children preferentially get transplant listing because that's important as well, right? So there's a lot that can be done for those kids once they survive that early period.
Okay. I understand that 1/3 of these surviving recessive PKD patients will need a transplant within a 10-year period of time. Is that also a correct statement?
You know, I think it's not so critical to say like these black or white statements. I think it's critical to sort of follow each child as they go through to see when they're likely to develop kidney failure. It is true in general that these are kids that are going to develop kidney failure. So that's correct. Yeah. Whether it's before 10 years, whether it's before 15 years, right? I think that is a little bit dependent on the child and the two genes that they get and what's causing the disease, right? The same way we talked about ADPKD having sort of this distribution of ages and characteristics.
Okay. I have read that there is cause to be optimistic for the ARPKD patient in that ARPKD is no longer considered a fatal condition. 20 years ago or so, about half the children born with ARPKD survived to their 10th birthday. Now more than 90% of those children survive the newborn period and reach their 20th birthday, and only 50% of those survivors don't require dialysis or transplant. Can you discuss with us how we made this progress?
Well, I think in general, we have gotten better at delivering care, right? Like all kinds of care. We're better at treating the liver disease associated with ARPKD. We're better at treating and managing the symptoms of kidney disease. We're better at maintaining graft survival for those people who get transplanted, right? We know more about reducing risk of rejection and things like that. So I think a lot of the gains you see for diseases where there still aren't cures is because simply the care that we're giving, that's the supportive care for the condition, has gotten better.
Okay. Let's talk for a minute about the importance of genetic testing and prevention for polycystic kidney disease patients. Why is it important in this day and age for PKD patients to consider genetic testing?
Well, I would say that there is controversy still about the role of genetic testing in PKD, and now I'm speaking specifically about ADPKD. It's very common for parents who have a child with ARPKD to then get tested and sort of to be aware of that condition. But for people with the autosomal dominant polycystic kidney disease, the reason for genetic testing in that case there are a couple of reasons that we would recommend it. One is if you're the first person in your family with ADPKD and there's no family history, then we may want to do genetic testing to really make sure we understand that it is a disease caused by either PKD1 or PKD2. The other time we would consider genetic testing is if there's a family member with PKD who's coming up for transplant and there's a young donor, someone who wants to give that person a kidney within the family, then we would want to test the person who's going to transplant and make sure that young person in the family doesn't also carry the gene that might cause ADPKD later on for them. So in that case, we would definitely want to do genetic testing. And the third time when we offer genetic testing is for someone who's starting a family who's thinking about something we call pre-implantation genetic testing. And so we talked a lot about with ADPKD, if you have children the normal way, there's a 1 out of 2 chance that your child will have ADPKD. But if you go through in vitro fertilization, and now we test those early embryos to see which carries the PKD gene and which does not, then we could implant the ones that don't carry the PKD gene. And that's a way of a way for some people who think that's appropriate therapy of making sure that PKD comes out of the family, right? Because then if you have a child that doesn't have PKD, they can't then pass it on after that. It ends with that child, right? The disease course ends in that family at that point. And so some people are very excited about that promise of that technology called pre-implantation genetic testing. So, you know, for all of those reasons, we would consider genetic testing. We are starting to think that in the future, there may be therapy based on the specific genetic variant that you have. We're not there yet, but we think that that might be where the future is heading. And so if that's the case, then there may come a time when we say to everybody, hey, let us get you genetic tested, let's get you genotyped so we can figure out what's the best treatment for you. They do this kind of treatment approach in cancer a lot. So you may see genetic testing being done a lot in the folks you know who have cancer. And so we may be at that point at some stage, but we're not there quite yet. We're, I think that's somewhere, hopefully somewhere in the future, in the 5 to 10 year future, not in the far future, but in the near future.
Okay. We have a question from Mr. Kent Bressler. He is the Vice President of Kidney Solutions, our sponsor. And Kent was a preemptive kidney transplant patient many years ago, I believe 1980s or so. And he's asking if preemptive kidney transplants can play a role in helping people that have polycystic kidney disease.
Yeah, of course, right? So when the kidneys fail, the choices for kidney replacement therapy are either transplant or dialysis. And we would prefer if everyone could have a preemptive kidney transplant and not need to go on dialysis, because we know that the length of life, the quality of life is better with a transplant than being on dialysis. So we really encourage people as they're starting to get to that point when the kidneys are starting to fail, to talk to family, to talk to friends, to to ask people to advocate for them to try and find that donor so that they don't have to go on dialysis and be on the waiting list. Because often people are developing end-stage kidney disease with PKD when they're still fairly young and fairly healthy, right? So the things that keep older patients with, let's say, diabetes off the transplant list, such as a bad heart or some other medical problem, are typically not problems for people with PKD. And so we really advocate very strongly for preemptive kidney transplant.
Okay. Can a PKD mom absent genetic pre-implantation and in vitro fertilization, can a PKD mom have children?
Sure, of course.
And what is the likelihood that they may pass this disease along to their child?
It's the same risk. It's that 1 out of 2. So the PKD mom, just like the PKD dad, has 2 copies of PKD1 and 2 copies of PKD2. And so if the PKD, let's say it's a PKD1 mom, where she has 1 disease-causing copy of PKD1 and 1 normal copy, she will pass 1 of those on to her offspring. So if she passes the normal one on, that child will be normal without PKD. If she passes the disease-causing one on, the child will develop PKD. So the mom or the dad, it doesn't matter which parent it is, it's a 1 out of 2 chance for the child to get PKD with autosomal dominant polycystic kidney disease.
Okay. You talked to us briefly about pre-implantation genetic diagnosis and in vitro fertilization as an option for couples where one of them has PKD. Can you give us an explanation of how that works and why the result is the child does not have or is not passed along polycystic kidney disease?
So maybe I didn't explain it clearly enough before, but this involves a few steps. So first it involves, for the parent that has PKD, it involves knowing the genotype or the genetic variation that's causing the disease in that gene. So we need to be able to know what that is because we need to be able to test for that. And then the egg and the sperm are put together in a dish and there's fertilization that occurs. That's the in vitro fertilization part. Just means that the fertilization is happening inside a dish. And once that embryo grows large enough, we take a probe and take a few cells out of that embryo and then use those cells to do genetic testing. And we see whether those cells from that embryo contain the disease-causing PKD1 gene or not. If they don't, and the embryo is otherwise normal, meaning all of the chromosomes are normal and everything else looks good, then we would consider that an embryo for implantation. So when couples go through this cycle, they typically have anywhere from 4 to 5 embryos that then get tested. And, just like it's a 1 out of 2 chance, if you have 4 embryos, then maybe 2 of them would not have the disease. And then those 2 might be embryos that we would consider for implantation.
Okay. When I was doing my research for this broadcast, I noticed that you spoke at the American Society of Nephrology 2023 Kidney Week in Philadelphia, and got awful early in the morning too, Dr. Dahl, on updates in inherited diseases in 2023. Can you please highlight for us what your talk was all about?
Yeah, so this was the start of a research day where the entire day was focused on thinking about how our knowledge of genetics is changing our understanding of kidney disease. So it wasn't specifically a talk about PKD. It was a talk about where we are in 2023, at the end of 2023, in terms about thinking about genetics and kidney disease. And we now have access to a pretty low cost way of doing genetic testing. And so we really are encouraging people, doctors who are not very familiar with genetic testing, to become more familiar with genetic testing. And so to understand some of the risks and benefits involved. We know that with ordering more testing, there has to be a workflow in place so that people feel like they're getting well counseled before they get the testing. They know what some of the risks and limitations of the testing are. They know something about the costs. They know something about how this will impact their ability to get medical insurance or life insurance or disability insurance. There are a whole kind of collection of things that we want to make sure that people really understand and discuss comfortably and easily with people who may have kidney disease before we start bringing kidney genetic testing into the mainstream in the kidney clinics. And so the talk was really how to do that and how to do it in a way that's not causing undue burden to the care providers, but is still respectful and thoughtful in terms of the care we're delivering to the patients.
Okay. Do you have any final statements that you would like to make tonight to our audience? Is there anything that I failed to ask you about or that you think are important, or is there anything that you think is important for PKD patients?
I would say there are two main messages maybe that I would say. One is sometimes people will come to us and or not come and say, well, I'm feeling fine, I'm doing fine, I'm going to see them when I'm in trouble. And one message, one clear and important message is, no, we want to see you so much sooner than that, because there's a lot of information we can share with you that is only going to be of value if we get to you before you need transplant or before you need dialysis, right? So come early, come often, talk to us. The other thing is, I've spent my career in academic institutions, and we can only find cures for PKD if there are people that come and are, volunteering of their time and their perspectives to be in our clinical trials. And so, if it's possible to do research, and if that's something that appeals to you, we're always looking for people that want to share that. A lot of people do it for altruistic reasons. A lot of people do it because they think it may help their family if it doesn't help them. But it's really critically important. And I think the PKD Foundation is a great way to just kind of stay in touch and hear about those research opportunities and maybe consider participating. We learned a lot about doing clinical trials through the pandemic. And so we're trying hard to make the burden of the trial less and less for the people who want to participate in those trials, because, for some it's a day off of work, or for some it's, coming into a place to do those trials. And so we're working on that part of it too. And then I would say my final message is, if you think your doctor is not hearing you, which often can happen, it may be either because we're focused on something else, or because we're really not hearing you, and you just have to keep saying it until we hear you, because that's the only way that care changes for people, is if we suddenly realize, like, so for example, in the clinical trial space, we're now starting to pay a lot of attention to what we call patient-reported outcomes, right? How people tell us they're feeling, and do they have pain, and do they feel better on the drug? And we wouldn't have really known that was important until we started talking to people and saying, what are we missing from these trials, right? Like, how come we're not doing well with these? And so that's a huge change in how we do clinical trial design, is we really focus a lot on patient-reported outcomes, but we wouldn't have known to do that unless we get feedback, right? So that's the kind of interaction we're really hoping for from all of you.
Okay. I want to thank you, Dr. Dahl, from coming on tonight and doing such a wonderful job of educating all of us. I want to explain to our audience, this is our third attempt to try and get Dr. Dahl's words recorded. The first time I ended up in the hospital. The second time, I don't know what happened, but for some reason or other, StreamYard did not record the broadcast. We've tried to do all this before. And as you can see, a woman of her education, her knowledge, her experience, and her background, to be patient with a sick old man and to be willing to come back for a third time. Neera's not just an ordinary guest on my broadcast. Neera is my friend. And I just want to say thank you so much for being patient with me. And I'm so happy that we finally got this done. And I promise you, there's no corner of this earth that I'm not going to share this broadcast.
Oh, well, thank you.
I hope many people get a chance to see this, and I'm urging my friends, please share this broadcast. It's such an excellent presentation of some very difficult issues for PKD patients. So I just want to say thank you for being so patient with your Uncle Jim. And
I'm glad you're feeling so much better, Jim. I hope I see you in March, right? But I'm glad you are feeling better.
Thank you. On Monday's my last day of cardiac rehab, and I'm seeing my kidney doctor on Tuesday next week. So we're going to get cleared, and I do feel a little better. I'd like to be back to 100% before February. That's when the NKF is having their Kidneys on the Hill date, and I'd like to be okay for that summit. So, but at any rate, I hope to make it to the PKD Foundation's gig this year, and maybe I'll get a chance to shake your hand. So, wonderful job. Just did such a great job, and I'm in your debt, my friend. Anything I can ever do, just pick up the phone and call me.
I will do that. Thank you so much for having me on. I really appreciate the chance to talk to you, to talk to everyone who listens. It's always what we're here for. Thank you.
Okay. I'm going to let you go, Doc. I got a couple of things to button up with our audience, but I do want to say what a tremendous job you did tonight, and thank you again for your patience.
Thank you. Bye-bye.
Bye-bye now. All right, that's our broadcast for tonight. And yes, I actually managed to record this one. So I've got 2 more guests on in the month of December. I'm giving you Christmas week off. I may do a thank you broadcast over the Friday after Christmas. And we start the first of the year. I'm booked through February. I'm trying to get some more important people on, doing a little negotiation. So I will keep you posted what's happening with the broadcast. And I thank you so much for taking time to come on tonight. And wow, great comments tonight too. I thank everybody in the comments. So I'll see you next week, and watch this space for more interesting broadcasts like Dr. Dahl and Amanda Giannetti and all of it. Just been a great year as far as getting people to talk to us. So take care. Have a good evening. We'll talk soon.